So before moving to any topic, it is the most important quote in our clinical practice. As we said, Darshana Sparshana Prasnehi, listen to the patient, he is telling you the diagnosis. Because the importance of the shoulder joint is the joint with maximum range of motion with least stability. So any pain during the movements means there will be a pathological condition behind the shoulder and we have to diagnose it. So proper diagnosis with a apt history taking. So 85% of the diagnosis is based on the clinical interrogation, then investigation, and finally the X-ray, MRI like. Okay, so proper investigation and interrogation is necessary, and you have to diagnose it first. Only after diagnosis, go for your treatment. Okay, so the basic of the shoulder joint is the ball and socket joint with most unstable. That is, the stability of the joint is sacrificed for the mobility of the shoulder joint. And it's very important that the humeral head is 1/3 of the humeral head, because the glenoid cavity is shallow like this, and humeral head is 3 times than outer aspect of the shoulder. So 1/3 of the humeral head is in contact with the glenoid cavity, and so that there will be maximum range of motion like a circumduction movement. Okay, and there will be a lax joint capsule so that we get maximum range of motion, but sacrificing the range of stability, the joint attains maximum mobility. So any issue related to its static and dynamic stability create a pain. So this is the basic of the shoulder joint pain compared to all other joint like knee joint or back pain or any other joint, especially in the sports injury. So the diagnosis is very important, and it is the most important joint with very difficult to cure. So that is the most important area. Okay, and the stability is related to Korsakoff. This is the basic anatomy, and it is a very important area. There are 2 types of stability. That is, one is static stability, and the second one is dynamic stability. This is a very important aspect related to shoulder joint pathology. And static stability is maintained by a thick labrum and a joint capsule. A labrum and a joint capsule is the joint capsule, and we can see the glenoid labrum, outer glenoid labrum and the joint capsule. It is related to the static stability. At the name indicates static means during the resting position, the stability is maintained by the joint capsule and the glenoid labrum. And most important thing, another one is the glenohumeral ligament. This is the humeral head and this is the glenoid cavity. We can say the superior glenohumeral.
Sir,
Hello?
Sir, the slide is not changing, sir. Can you check that one? The slide that is not changing.
Again. Change in la?
ഇല്ല sir, change ആവുന്നില്ല.
Enable editing click ചെയ്യോ? Okay. Protect the view this file origin from inherent location maintenance.
അതിപ്പോ ചേഞ്ച് ആയിട്ടുണ്ട്.
ഇപ്പൊ ഓക്കെ ആണോ?
ഇപ്പൊ ചേഞ്ച് ആയി.
ഡോക്ടർ, ആ എനേബിൾ എഡിറ്റിംഗ് ഒന്ന് കൊടുക്കുമോ മുകളില് ആ PDF ല്? ഐ മീൻ ആ സ്ലൈഡില്.
ശരി. ഓക്കെ, അതായിരിക്കും അല്ലേ? ഇനി നമുക്ക് നോക്കാം. ഓക്കെ, താങ്ക് യു.
ഓക്കെ ഡോക്ടർ.
Okay, sir. Okay.
The important thing is the static stability. It depends on joint capsule and the glenoid labrum. The first thing, and second one is glenohumeral ligament. That is superior glenohumeral ligament and middle glenohumeral ligament and inferior glenohumeral ligament. These are the 3 glenohumeral ligaments which stabilizes the shoulder. So this joint capsule and the glenoid labrum and the glenohumeral ligament. These are the static stabilizers of the joint. This is very important in the normal clinical practice. That is like frozen shoulder or periarthritis. These are the most widely seen case in the normal clinical practice. The patient present with the shoulder pain, it aggravates in the night. Initially, flexion is affected, and in later stage, internal rotation is affected. This is the basic of any adhesive capsulitis or periarthritis. So in such cases, mobilization technique, we know the mobilization techniques of the shoulder. So any mobilization techniques of glenohumeral ligament relieves the pain in case of frozen shoulder or adhesive capsulitis. So static stabilizers are very important in the normal clinical practice. But in case of sports injuries or in any other activity-related injuries, there are dynamic stabilizers. Most importantly, the rotator cuff muscles, supraspinatus, infraspinatus, teres minor, and subscapularis. So, considering the frozen shoulder, periarthritis, adhesive capsulitis, and OA shoulder, and synovitis of the shoulder, all are related to these static stabilizers. So, mobilizing all these ligaments or a capsule itself relieves the pain. So in our practice, incorporating these mobilization techniques of the shoulder relieves the pain in case of periarthritis of frozen shoulder or all related to static stabilizers. For in case of sports injuries or mobility related issues like rotator cuff, the treatment is entirely different. In case of static stabilizers related injuries or pain, mobilization is the treatment of option. And in case of a rotator cuff tear, like dynamic stabilizers, initially immobilization techniques to 2 to 3 weeks. After that, we have to mobilize the patient with range of motion exercise. Okay. Before that, there are important, very, very important is knowing the shoulder range of motion. Initially, the flexion. You not because after in each area of the class, I will explain what is flexion, extension, abduction, extension, rotation. So you have to know the each range of motion of the shoulder. So this is a shoulder flexion, like parade, the shoulder flexion, and it is the shoulder extension. Okay, and it is the abduction. Sorry, it is the adduction. It is the abduction, internal rotation, external rotation. So it is important because the internal rotation of the shoulder is related to subscapularis muscle. Okay, and the external rotation is teres minor. Okay, and infraspinatus. And the abduction is related to supraspinatus. So you have to know the exact range of motion of the shoulder. So it is the flexion, and I think you have to know it. So it is the shoulder flexion, shoulder extension, and it is the abduction, and it is the internal rotation and external rotation. And another movement is the circumduction. So it is very important. And these are the important ligaments of the shoulder, and this is the surface anatomy. Okay. So coming to the basic anatomy related to the dynamic stabilizers, there are 4 muscles of the rotator cuff. One is the supraspinatus, infraspinatus, teres minor, and subscapularis. Which is the most important in dynamic stabilizers. That means it control because there is a shallow glenoid cavity and a large humeral head, and it is statically stabilized by the glenoid labrum and the joint capsule and anterior middle and superior middle and inferior glenohumeral ligament for static stability. And for dynamic stability, it is supported by the rotator cuff muscle because it is a shallow one and large humeral head, and it is supported by the supraspinatus, infraspinatus, teres minor, and subscapularis for the mobility of the shoulder. Okay, and the origin, insertion, and action is more important considering the anatomy and for better understanding of the pathology. Okay, so we can see this is the subscapularis muscle. There are 4 muscles: supraspinatus, infraspinatus, teres minor, and okay. You can see the supraspinatus is the back of the shoulder, back of the scapula or shoulder. It is the anterior shoulder. We can see supraspinatus muscle. Supraspinatus muscle originated from the supraspinous fossa and beneath the acromial arch, and it inserted into the greater tuberosity. So it is a supraspinatus, and infraspinatus fossa starts from the infraspinous fossa and attached to the greater tuberosity. And another one is the teres minor. It also from the lateral angle of the scapula and greater tubercle. So it is the posterior muscle, supraspinatus, infraspinatus, and teres minor. Together it attaches to the greater tuberosity. Okay, and in the coming to the anterior aspect, the largest rotator cuff muscle, which is the subscapularis. As the name indicated, it is the inside the scapula, over the rib cage, inside the scapula, and it attaches anteriorly to the lesser tuberosity. So the attachment and origin is very important for assessing the movements of the shoulder. So considering the supraspinatus, we can see this is the shoulder joint, and I will show you. So, okay, we can see this is the supraspinatus muscle. This is the supraspinatus. The red color one is the supraspinatus muscle. It originates from the supraspinous fossa, and we can see the coracoacromial arch, and it attaches the greater tuberosity. Okay, it attaches the greater tuberosity, and by the contraction of the supraspinatus muscle, the shoulder abducts. Okay, the primary function of the supraspinatus muscle is the abduction. Abduction means moving away from the shoulder. Okay, laterally away from the shoulder is the abduction. So the abduction of the shoulder is done by the supraspinatus muscle along with the deltoid muscle. Okay, so the function of supraspinatus is the abduction of the shoulder. It is the most important thing. Abduction of the shoulder is controlled by the supraspinatus muscle and the deltoid muscle. It is the first thing. And second one is infraspinatus muscle and teres minor. You can see that infraspinatus. It is the back of the shoulder. We can see the back of the shoulder. It is the back of the humerus and the greater tuberosity. And if the infraspinatus and teres minor, can you see me, doctor?
Yes, sir.
Okay. So it is the supraspinatus muscle. Supraspinatus muscle originated from the supraspinous fossa. You watch my shoulder. Start from the supraspinous fossa and attaches the greater tuberosity here. So by the contraction of the supraspinatus muscle, the shoulder abducts. Okay, by contraction of the supraspinatus muscle, the shoulder abduct. So the function of supraspinatus is to abduct the shoulder. Okay, then from the back there is infraspinatus and teres minor. Okay, by contracting the infraspinatus and teres minor, there will be external rotation of the shoulder. Okay, so it is the subscapularis or the infraspinatus muscle, and there is teres minor. So by the contraction, infraspinatus start from here and teres minor start from, and it attaches from the back to the anterior aspect of the greater tuberosity. So with the contraction of infraspinatus and teres minor, there is the external rotation of the shoulder. You can see this is the back of the shoulder. So by contracting the infraspinatus and teres minor, there is the external rotation of the shoulder. So the function of infraspinatus and teres minor is to externally rotate the shoulder. Okay, it is the second one. And another one is the subscapularis. Subscapularis is from the internal aspect of the scapula. Subscapularis, the internal aspect of the scapula, inner border of the scapula. It starts from the inner aspect of the scapula and it attaches to the lesser tuberosity. All the three muscles of rotator cuff, supraspinatus, infraspinatus, teres minor, it attaches the greater tuberosity, slight anteriorly. Okay, and slight posteriorly and superiorly. And in subscapularis, it starts from the inner aspect of the scapula, inside the scapula, and it attaches to the lesser tuberosity. Okay, while contracting, this is the subscapularis, this is the anterior. It is from the anterior view. So while contracting the subscapularis, you watch my hand, it is inside the scapula and it attaches to the lesser tuberosity. By contracting the subscapularis, there is the internal rotation of the shoulder. Is the most important dynamic stabilizers, and is the kinesiology, that is the movement physiology. So for the abduction of the shoulder, supraspinatus; for external rotation, infraspinatus and teres minor; and for external rotation, infraspinatus and teres minor; and for subscapularis, internal rotation. Never by heart. This, just understand the origin is the supraspinous fossa to the greater tuberosity, so that you can abduct the shoulder. And infraspinous is back of the shoulder, infraspinous fossa and teres minor. While contracting the infraspinatus and teres minor, externally rotate the shoulder. And subscapularis is the inner aspect of the scapula. So contracting the subscapularis, there is the internal rotation of the shoulder. It is the most important kinesiology or the movement physiology of the shoulder. Okay. So this is the subscapularis. You can see the rib cage. You can see the rib cage, and it is the inner border of the scapula. Okay, it is the subscapularis. As the name indicates, it is the subscapularis, and it attaches to the lesser tuberosity. Okay, so while contracting the subscapularis, there is the internal rotation of the shoulder. Okay, there is the internal. This is the external rotation and the internal rotation. So internal rotation is determined by the subscapularis contraction. Okay, and you can see this is the supraspinatus. This is the view we can see in the MRI of a shoulder. Usually we directly go to the report. If you are looking to the film of an MRI, you can see the real picture like this. So it is the supraspinatus muscle, supraspinous fossa, attached to the greater tuberosity. Okay, and this is the deltoid muscle or the upper humerus. Okay, it attached to the deltoid tuberosity, and together with supraspinatus, the deltoid muscle help in the abduction. It is very important movement physiology. Okay, and there are common terminologies in our practice. We can see in the modern orthopedician prescription. So better to understand these cases like RCT. If the doctor diagnosed as a RCT, means this is a rotator cuff tear. Okay, we can see very important for the diagnosis in the modern prescription. Okay, it is a RCT, means rotator cuff tear, and PAS means periarthritis of shoulder. In many prescriptions of modern practitioners, we can see these terminologies. And another one is the CBN, cervical brachial neuralgia. That is the neck pain radiating to right or left upper limb. Okay, and the RDS, recurrent dislocation of the shoulder, and SI, mean shoulder impingement. These are the common terminologies that related to the prescription of a shoulder pathology. And moving to the diagnosis of a shoulder. Before proper investigation, there will be proper examination and history take. So, if a patient came to OPD with a shoulder pain, you ask the patient where is the exact location of the pain, because shoulder is the most important joint. With each and every point of pain have different diagnosis. If the pain on the top of the shoulder, it may be AC joint diagnosis. If the anterolateral aspect of the shoulder, it may be a rotator cuff. It is if the pain and tenderness of the deltoid tuberosity, it is a rotator cuff tear. If it is the anterior and posterior margin, it is a labral tear. So the diagnosis is very important, especially the pain and tenderness. So in case of a shoulder diagnosis, the exact pain, you have to ask the patient where is the exact location. If the shoulder pain, never diagnose another like ababahuga. Okay, diagnosis of ababahuga is okay, but the clinical condition of ababahuga may be more than 27 or 30 diagnoses in the modern aspect. Ababahuga, we can have a treatment option, but before adopting a treatment, you have to specifically diagnose the condition, because each and every diagnosis is determine that exact treatment. For a periarthritis of shoulder, never immobilize the patient, you have to mobilize the joint. For a rotator cuff tear, initially you have to immobilize the patient for 2 to 3 weeks. After that, you have to mobilize. Okay, so for exact pain and tenderness, you have to diagnose exact. You have to ask the patient where is the exact pain, where is the exact tenderness, and how it happens, in which moments. The patient completely, the pain on the abduction, it means it may be a rotator cuff tear like supraspinatus or a deltoid injury. If the pain comes in the internal rotation, it may be a periarthritis of shoulder or a subscapularis injury. If an external rotation pain, it may be a teres minor or infraspinatus pain. Okay, so the exact pain and tenderness location is very important for a basic diagnosis. And based on that diagnosis, you have to go for the further examination of the shoulder. Okay, so first one is the top of the shoulder. Can you see Dr. Kanandalo?
Yes, Dr. Kanandalo.
Okay, in the shoulder, okay.
Yes, Kanandalo.
Okay, if the pain on the top of the shoulder, if the patient, the first important thing is in the corona era, never sit 2 to 3 meter away from the patient. You have to touch the patient. You have to analyze the range of motion by touching the patient. So if the pain complaint over the top of the shoulder, if you are palpating a patient, you feel the tenderness over the top of the shoulder. It is in most cases, even in allopathy, we are not diagnosing the AC joint pathology because they are not touching the patient because of the corona. Even after the corona, even before the corona, we are touching the patient. We are properly touching, we are properly assessing the range of motion. So from the, if the pain and tenderness over the top of the shoulder, we can see this is the clavicle. Okay, it is the clavicle and it is the acromioclavicular joint, that is the AC joint. If the pain on the top of the shoulder, it is the AC joint pathology or acromioclavicular joint pathology. Okay, we can see in detail in next area, we can see what is the AC joint pathology. Okay, or if the pain on tenderness over the top of the shoulder, it is the acromioclavicular joint pathology, first one. And second one, if the pain typically in front, okay, it is the pain typically in front and lateral aspect of the shoulder. Typically, the pain over anterior and lateral aspect of the shoulder, especially if the shoulder is in extension. It is the flexion movement and it is the extension movement. Okay, so if the patient, ask the patient to extend the shoulder like this, and we can see a groove, that is the subacromial space. If the pain over the anterior and lateral aspect of the shoulder, it means it is a rotator cuff pathology. If a shoulder in extension and pain on the anterior and lateral aspect of the shoulder, it is a rotator cuff pathology. This is the second one. And another pathology in the window cleaning position. Window cleaning position means we never clean the window like this. We clean the window like that. Is the mild abduction. Abduction means away from the body and internal rotation. Okay. This is the abduction. Can you see, doctor? Okay. Okay. It is the abduction and internal rotation. So there are many movements, not only this window cleaning position. Okay, I have a patient from abroad. He's a tabellist. Okay, after doing 12-hour continuous tabella, he got severe pain on his shoulder. So what is the movement like this? So it is the abduction and internal rotation. Okay, this is the movement. So the window cleaning position, bathroom cleaning position. Okay, so in typically abduction and internal rotation, we are cleaning something very firm cleaning or hard cleaning, cleaning the bathroom, weekend cleaning the bathroom or car or any window cleaning position or tabella or any movements with abduction and internal rotation. If it creates a pain, it is the shoulder impingement. This is the condition called the shoulder impingement. Okay, so first the top of the shoulder AC joint pathology, anterior and lateral aspect of the shoulder, rotator cuff here, and the window cleaning position, pain on abduction and internal rotation movements, it is the shoulder impingement. And the fourth one is pain all over the shoulder. There are certain pathology, it may be traumatic or non-traumatic. It will come in the next slide. And another one is the pain along the deltopectoral area. It is very important. This is the pectoralis major. You can see this is the pectoral area, my chest. This is the pectoral area and this is the deltoid muscle. This is the pectoral area and deltoid. So there are some pain over the deltopectoral area. The deltopectoral area pain is more confusing because there is no specific diagnosis. With this specific point, we can diagnose the pathology because in case of a rotator cuff pain, rotator cuff pathology, there will be pain and tenderness over the deltopectoral area. In case of a labral tear, there may be pain. Okay. So, if the pain pathology or a biceps tendonitis, in most cases, if it is associated with an injury, okay. There are several conditions with pain and tenderness over the deltopectoral area. So it is non-specific diagnostic clue. Mostly in case of a rotator cuff pathology and a biceps tendonitis, usually you can palpate, we can feel tenderness on the deltopectoral area. And the fourth one or fifth one is the in front along the anterior arm. The pain in front along the anterior arm. It is very important. That is the biceps tendonitis. Okay. Pain along the anterior aspect. In front along the anterior aspect of the arm. It is the biceps tendonitis. And another one is the pain along the arm towards the deltoid insertion. We can see it is the deltoid muscle. It is the deltoid tuberosity. Okay, it is a deltoid insertion. And in several cases, in the chronic cases of deltoid muscle or rotator cuff pathology, patient mostly come to the doctor, I have no pain here, but severe pain and tenderness over the deltoid insertion. There is no pain though, no tenderness, but restricted range of motion and complaint of pain and tenderness over the deltoid insertion. This is the deltoid insertion area. There will be no pain and tenderness over here. Patient having restricted range of motion, but pain and tenderness over the deltoid insertion. It is the typical presentation of a rotator cuff pathology. Okay, and long lever arm with elbow extended. If a patient complaint of pain with long lever arm means elbow is extended and the wrist is extended. Okay, long lever arm with pain is extended. Long lever arm with elbow extended. This is the elbow extended position. If you are taking 4 or 5 kilogram weight, holding with elbow extended position, if you can feel a pain when compared to the opposite side, okay, when compared to the opposite side, if you feel a pain over your shoulder with a lifting a pain with elbow extended, that is the long lever arm with elbow extended, it indicates a rotator cuff tear. It may be a rotator cuff tendonitis or rotator cuff partial tear. Any rotator cuff pathology, there will be long lever arm with elbow extended pain. Okay, and another one is the painful in night while sleeping on the same side. While sleeping on the same side, mostly it may be a rotator cuff pathology, it may be a periarthritis of the shoulder. If it is associated with injury or a trauma, mostly it is rotator cuff pathology. If the patient is above the 35 or 40 having periarthritis, in this case also there will be painful shoulder while sleeping on the same side. And another one is the repeated overhead activities, the shoulder in internal rotation, like badminton. Okay, repeated overhead activity with the shoulder in internal rotation, like badminton, etc. Maybe the diagnosis may be a shoulder impingement. And in young adult with anterior and posterior joint line pain, young adult with anterior and posterior joint line pain, the diagnosis is labral tear. Okay, and it is very important that if the patient is having a shoulder dislocation, if a patient present with a shoulder dislocation, and if he is a young adult, a patient with a young adult patient with a shoulder dislocation, improper management, the possibility of labral tear is more. If the patient is above 40 with a history of dislocation, there will be a possibility of a rotator cuff tear. Okay, that means if a patient came to OPD with a shoulder pain, chronic shoulder pain developed after recurrent shoulder dislocation, if the patient is a young adult, there will be the pain is mostly due to labral tear. If the patient is older than 40 or 50, the dislocation is associated without a trauma, it may be infective arthritis, it may be an inflammatory arthritis, it may be a OA shoulder. Okay. And there may be a referred pain. Referred pain means the pain from another areas like CBN, cervical brachial neuralgia. And the differential diagnosis of CBN with shoulder pathology is if a patient is having pain radiating from shoulder to elbow, and shoulder related pain never radiate below the elbow. This is the most important thing. If the pain is radiating from shoulder to upper arm or below the elbow, may be mostly due to cervical pathology. And any pain which is not radiating, which is radiating below the elbow, mostly it is cervical pathology. And one thing is important, the shoulder pain never radiate below the elbow. Okay, if any pathology like rotator cuff tear, periarthritis, shoulder impingement or shoulder fracture, the pain related to shoulder pathology never radiate below the elbow. And if it is related to cervical pathology, it depends on the dermatomes of the cervical nerve roots. Okay, it is very. And muscle wasting, if deltoid muscle wasting, we can say axillary nerve injury, is mostly seen in clavicle fracture. Especially in the medial 1/3 fracture, there will be axillary nerve injury. In case of an axillary nerve injury, you can see the deltoid muscle wasting. Okay, and in case of suprascapular nerve injury, there will be supraspinatus and infraspinatus muscle wasting. Okay, so considering the pain, tenderness and location of the pain, you have to make a provisional diagnosis. And after that, by clinical examination, go for a exact diagnosis. Okay, and we can see this is the more important diagnostic clue. We can have a differential diagnosis. A patient came to OPD with severe pain over the shoulder and radiating to his hand, and he's always keeping this position. So the typical Saha position is the typical position we can see in cervical IVDP. It is not related to shoulder pain. If she is relieving the pain in this position, she got complete relief of the pain. If she is taking the hand down, again pain start. While lifting like this, patient relieves the pain. This is the typical presentation. That is the Saha position. Saha position, if patient get relief, it is cervical brachial neuralgia or a cervical IVD. It is a typical presentation of a cervical IVDP. If the patient pain aggravate on this position or any pain that aggravate if the upper limb is above the shoulder level, it means it is a carpal tunnel syndrome, and patient got relief. If the patient having pain over, if pain is keeping the hand over the above the shoulder, patient have severe pain and numbness over the shoulder. If it is getting down, if it patient got maximum relief in carpal tunnel syndrome. It's both are entirely different. If the patient present with a shoulder pain radiating below the elbow, so for diagnosing a cervical brachial neuralgia, it is very important. If the patient presented with a radiating pain below the elbow with a specific dermatomes and patient got relief with this Saha position, it is cervical brachial neuralgia. Okay, in case of a carpal tunnel syndrome, CTS, it is very important. This is a vague shoulder pain radiating from hand to shoulder. Vague shoulder pain may radiate from hand to shoulder, and pain aggravate with this Saha position, and complete relief if he is releasing his hand to down. If she released her hand down, there will be complete relief in case of CTS. And if she is holding a knife or mobile like this, there will be numbness, pain and paresthesia over the upper limb. If she releasing her hand, the pain is reduced. This is the presentation of a carpal tunnel syndrome, and this is the presentation of a cervical brachial neuralgia. Before going to treatment, in case of a shoulder pain, okay, in case of a cervical brachial neuralgia, the radiating pain in case of C4, C5, up to C5, the pain radiating only up to elbow. So with the shoulder pathology, C4, C5 or C3, C4 IVDP should be differentially diagnosed. Okay, and we can see the another pathologies. So patient came to OPD. You can see there is a deltoid muscle wasting here, deltoid muscle wasting. You can see this is the typical infraspinatus. So this is the spine of the scapula. You can see the supraspinatus area wasting. This is the infraspinatus area wasting. And we can see this is the deltoid muscle wasting. So there are certain pathologies like brachial plexus injury. There may be supraspinatus, infraspinatus and deltoid. Together there will be muscle wasting in case of a brachial plexus injury. In case of an axillary nerve injury, there will be wasting of the deltoid muscle. Axillary nerve injury, there will be wasting of the deltoid muscle, and there will be teres minor, because the teres minor and the deltoid is supplied by the axillary nerve. So any axillary nerve injury, there will be wasting of the deltoid muscle and teres minor. In case of suprascapular nerve injury, there will be suprascapular, that supraspinatus and infraspinatus muscle wasting. And in case of a chronic rotator cuff tear, there will be muscle wasting of supraspinatus and infraspinatus. So differential diagnosis is very important. If there is a suspected nerve root injury, like brachial plexus injury or axillary nerve injury or suprascapular nerve injury, and associated muscle wasting is there. If a patient presented with muscle wasting, you can send the patient for an EMG study. Okay, so you can write down this is a left shoulder, EMG left shoulder, or EMG left scapula. Okay, and if the suspected brachial plexus injury, it is very important that in case of a brachial plexus injury, pain will be usually less. The numbness will be usually less. There will be burning pain and the weakness. Okay, in case of brachial plexus injury, pain will be usually less, but weakness is prominent and numbness will be less. Weakness and burning pain will be more prominent in brachial plexus injury. So in cases of suspected brachial plexus, go for MRI brachial plexus. Or for differentially diagnosing from the cervical pathology, you write down MRI cervical spine with brachial plexus or MRI cervical spine with brachial plexus screening. Write down like MRI cervical spine with brachial plexus screening. You have to rule out cervical pathology and brachial plexus pathology. If a patient came with muscle wasting, you go for a EMG study, electromyography study. Okay. And this is a patient came to OPD, there will be no pain and the range of motion is not restricted, but patient is unable to lift the shoulder. There are certain cases there will be no pain on the shoulder and the range of motion is not restricted, but she unable to lift the shoulder. So in such cases, you can see this is the deltoid muscle wasting. The patient having deltoid muscle wasting, and because of the deltoid muscle wasting, it is like a subluxated shoulder. Okay, this is like a subluxated shoulder. Okay, so you suspect an axillary nerve injury. So you write down EMG shoulder or EMG axillary nerve, and you write down EMG deltoid. Okay, so you have to diagnose whether it is a chronic rotator cuff injury or an axillary nerve injury or a deltoid muscle injury. Okay, and there are differential diagnoses of shoulder pain. It may be arthritis, inflammatory arthritis, degenerative arthritis, and infectious arthritis. In these cases, in case of arthritis, it may be inflammatory, it may be a degenerative, it may be infectious or a CA. Okay, in case of a infectious arthritis, inflammatory arthritis and degenerative arthritis, you write down CBC, complete blood count, ESR and CRP. Okay, you write down CBC, ESR and CRP. Okay, it is the very important, and RF factor is very important, and TB is very important. In case of a shoulder with a diffuse pain and swelling over the shoulder, you have to write down TB shoulder. It is the most important area, extrapulmonary area where TB can be affected. Okay, so CBC, ESR, CRP is the basic investigation to rule out inflammatory pathology of your shoulder. Okay, and after, if there is any abnormality, if it is normal, go for an MRI. Okay, if it's having any other pathology like elevated ESR or CRP, if elevated ESR and CRP, elevated CRP, CRP is the typical presentation of infection. Okay, elevated CRP is the specific criteria for infective pathology. And if the ESR is normal values 10 or 20, and it is clinically relevant if the ESR is above 40 or 50. If the ESR is above 40 or 50, then only it is clinically relevant. Okay, and if the patient presented with the elevated ESR above 100, ESR above 100 and CRP above 100, you have to rule out CA. Okay, you have to rule out a malignant lesion. And in other pathologies like Crohn's disease or autoimmune infective pathologies, autoimmune inflammatory pathologies, there may be elevated ESR and CRP. And in case of CA also, in case of malignant lesions also, there will be elevated ESR and CRP, usually above 80 or 100. Okay, and in case of dislocation and instability and labral tear, traumatic and maybe a bursitis or tendinopathy. Okay, these are the osseous area, osteomyelitis and primary bone tumor, and any infection or any cancerous lesion we can simply diagnose with a shoulder X-ray. Okay, you can see a shoulder X-ray if the diagnosis, and this is the golden standard for tumor diagnosis. X-ray is the golden standard for a tumor diagnosis. So with a shoulder AP X-ray itself, you can diagnose a shoulder carcinoma or shoulder osteomyelitis or osteoarthritic changes. Okay, and reflex sympathetic dystrophy. If the referred pain, if pain referred from the left shoulder, maybe a myocardial infarction, and in case of a right shoulder, maybe a gallbladder anomaly, abnormality, or a cholelithiasis or a cholecystitis, etc. It may be a neuropathic pain, axial plexopathy or axillary nerve injury, cervical IVDP. Okay. And the investigations of the ultrasound, shoulder ultrasound, X-ray, MRI, and CT. And X-ray we will go in detail. And next the USG, ultrasound of the shoulder. In normal practice, ultrasound is applicable only in superficial joints. Okay, if a patient came to OPD with a knee pain, so if there will be a bursitis or a synovitis or any pathology related to patella, maybe a patellar tendon or a patellar pathology, infrapatellar bursitis, etc., you can diagnose with an ultrasound. But in case of IDK, internal derangement of knee like ACL, meniscal injury, we can't get an exact picture using ultrasound because it is a deep joint. We can't do any diagnosis with ultrasound. So in case of a superficial joint, we can have ultrasound study. So among that, shoulder is the most important joint. So in case of shoulder pathology like rotator cuff pathology, you write down USG shoulder. You see right or left shoulder. You may get supraspinatus tear, infraspinatus tear minus, or subscapularis tear. In case of bursitis, etc., you can have a diagnosis with a USG shoulder. But deep to the shoulder like labral tear. Okay, it is more deeper structure, glenoidolabrum. Okay, deep to the shoulder, labral tear, and in case of Bangart lesion or Hill-Sachs lesion, the ultrasound never get a proper diagnosis. So for the deep study of the shoulder, go for an MRI. For a superficial study like a rotator cuff, ultrasound is enough. Okay, and in case of MRI and CT, if the patient is having a complicated shoulder fracture, especially a humerus shaft fracture, patient may develop a wrist drop. So for rule out radial nerve injury, and in case of surgical neck fracture with greater tuberosity fracture together, or a multiple fracture or a comminuted fracture of the shoulder head, for surgical purpose, CT scan is important. Okay, CT is more structural and MRI is more functional. For assessing the rotator cuff muscle or labral tear, Bangart lesion or Hill-Sachs lesion, MRI is the apt. Okay, for diagnosing a bony lesions and a fracture
and a fracture.